Equity in Mental Health Treatment and Service Delivery. Presented by Dr. Denise Shervington.
So I will go ahead and introduce Dr. Shervington. So she is the Chair of Psychiatry at the Charles R. Drew University. She previously held clinical professorships in the departments of psychiatry at Columbia University and Tulane University. She's a graduate of the New York University School of Medicine. She's also received a Master's of Public Health and Population Studies and Family Planning from Tulane University School of Public Health. She completed her residency in psychiatry at the University of California, San Francisco, and is certified by the American Board of Psychiatry and Neurology. A fellow of the American Psychiatry Association, in 2018, she received the Award for Excellence in Service and Advocacy, prior to which she received the Jeannie Spurlock Minority Award. Dr. Shervington is also a member of the American College of Psychiatrists and serves on the Psychiatry Resident and Training Exam Commission. She directs the trauma portfolio at the Institute of Women and Ethnic Studies in New Orleans, which is a community-based public health organization. Dr. Shervington, we are so glad to have you here today and to kind of wrap out our day talking about equity and how we can do our best to ensure that that service delivery is happening.
Thank you. Good afternoon, everyone. I think by now you're probably a little fatigued, so I'm going to try to not be too heavy, even though this is a very challenging and difficult topic. I caught a little bit of the previous presenters. I've heard them several times, and I might be able not to present some of the material I had because they did. So thanks to my colleagues at Tulane. So I'm going to talk about health equity in the delivery of mental health services. And I'm going to ask you to bear with what can be somewhat challenging. It's hard at times for us to think that we have been participating in quite a bit of inequity for centuries in this society. But I want to share with you what the National Center for Traumatic Stress Network said in 2016. And it is that as it relates to communities of color, mental health cannot be solely addressed at the individual level. A social ecological framework to address the compounding and catalytic impact of historical trauma and ongoing structural violence resulting in community trauma must be adopted. And basically they said we have to acknowledge the history and we have to acknowledge the current ongoing structural inequities. So I'm going to share a little bit of the history just to give some level setting, just to see where, how and why does this problem exist. In 1858, Samuel Adolphus Cartwright, who practiced in Alabama, Mississippi, and then came to New Orleans, he created this mental illness called drapetomania. And this was for slaves who desired to run away and seek freedom. He said they should be treated as children and forced into submission. And if they disobeyed, they were to be beaten, the devil whipped out of them, and oftentimes killed. These were people who were seeking freedom. In fact, he described enslaved people in this manner, that like an animal in a state of hibernation, waiting for the external aid of spring to warm it into life and power, so does the Negro continue to doze out of vegeto-animal existence in the wilderness, unable to extricate himself therefrom, his own will being too feeble. These attitudes continued. The American Medical Association, which was founded in 1847, tried to close Black medical schools. They did not allow Black physicians to be members. And actually in 1947, when President Truman tried to fight for national health insurance, they engaged in and spent millions lobbying against Medicare, saying that this was a socialist program. The real reason was that the South feared that federally funded hospitals would have to be integrated. And so in 1964, when the civil rights legislation to desegregate hospitals that receive federal funding was enacted, nothing happened. However, in 1965, President Johnson took this on again. The attempt to create some kind of national health service was won in Congress, a lot due to the testimony, very passionate testimony of the African-American physician, Dr. Montague Cobb. And so the Medicare, Medicaid bill passed. And it was actually only when millions of dollars were released through Medicare, Medicaid, that the hospitals decided to desegregate. Up until that time, it was thought that white nurses shouldn't treat Black men, that Black people in general should be, if they happen to be in a hospital, should be in the basement. And these were the kinds of attitudes that prevailed. Also, when African Americans were considered to have a mental health condition, they were primarily put in systems that looked exactly like prisons. So I just want to share with you what Dr. Martin Luther King said, that of all the forms of inequality, injustice in health is the most shocking and inhuman because it often results in physical death. And so I know that this is why currently we are working to reduce inequities, but of course, to understand why, it always helps to know what the history was, and so what we must surmount. And achieving health equity actually comes with achieving racial equity, because with racial equity is the affirmation that all people, regardless of their racial ethnic group identification, their skin color, their physical traits, that they deserve an equal opportunity to experience well-being, health in a just society. We must accept that this has not been so, and so double our efforts to see how we can change this. Because currently, race-based discrimination is still very deeply embedded in our social, political, and economic systems. And just remind you what happened last year on May 26, when we witnessed the murder, 9-minute plus murder of an African-American male. These systems are in housing, in education, in policing, the carceral system, economics, migration, and healthcare. And so I'm going to focus on healthcare because this is what we're here to talk about. And the first thing, and this is some of the work of Dr. David Williams at Harvard, and much of this comes from the report they just recently released, that there is a very complex interrelationship between race and socioeconomics, which is based on the history of enslavement and oppression. And that currently racism perpetuates disparities at the following levels, with institutional policies and practices that maintain racial disadvantage, and also at the interpersonal level where there's racial discrimination and biased treatment. We know that there are multiple inequities in healthcare because, to start with, access and quality of healthcare is very unevenly distributed across socioeconomic status. And who oftentimes happens to be at the bottom of the socioeconomic ladder are people of color. We know that many medical facilities are still very largely segregated, and in lower socioeconomic neighborhoods, or what lower socioeconomic folks have access to, is very much a lower quality of care. Oftentimes, these systems have much less financial stability. They have less access to diagnostic imaging equipment, and just higher barriers to the recruitment and retention of specialty physicians. And we do know there have been multiple studies that have showed that Black people receive fewer diagnostic and treatment options than any other racialized group. I happen to be at Charles R. Drew University, a historically Black and Hispanic serving institution, and our mission statement is about eliminating healthcare inequities, a specific focus to undo much of what currently exists. And as a result of these inequities, then we see the health disparities. And we do know, and COVID has shown this, that the racial differences we're seeing in health outcomes and the disparities there are not due to genetics. Even underlying hypertension, cardiovascular disease, we know that this very much is tied to socioeconomic status. Overall, African Americans, we experience worse health outcomes across our lifespan, again, driven by socioeconomic conditions. And as a result, these chronic health conditions that result, if you think about access to healthy foods, less stress, access to recreational spaces, all of some of these lifestyle related conditions, and that we also know might be also triggered by toxic stress, then they increase the risk of more severe illnesses, as said earlier, we've seen with COVID. We also know that many of these conditions have their roots in the physiologic consequences of excessive adversity early in life. And it appears that you've had a lot of information so far about childhood maltreatment and adversities. I will talk about it some, but I do acknowledge that it appears that you have had quite good information about these conditions. But I want to try to show the impact for children of color. So I'm not going to spend much time on this because it appears that you've had a lot of this today, the adverse childhood experiences at the interpersonal level happening in the household where there's abuse, neglect, or household challenges. But added to that, expanding the issues of adversities in childhood are also community and structural factors. So in addition to the conventional screening that came out of the ACE studies, in Philadelphia, they added community factors such as witnessing violence, experiencing racism and discrimination, living in unsafe neighborhoods where there's a lot of violence, being bullied, or living in foster care. These are some of the community factors that also contribute to adversity, early adversities. And I see that you watched the TED Talk by Dr. Nadine Harris-Burks, the California Surgeon General, in the much of the work that they've done, and their screener, the PEARLS, they've also added structural factors and community factors such as food insecurity and housing instability. These all contribute to some of the inequities and resultant disparities that we see in children of color. In 2016, a study was done that showed that ACEs also follow along the lines of disparities, that in terms of children experiencing ACEs, at least one ACE, the majority were Black children, followed by Latinx children, with Asians having the least. ACEs were more concentrated in children, Black children, whose mother had lower educational achievements. We also know that as a result of having these adversities, children were more likely, Black children, and this is where I'd like to focus in a little bit, that Black children who had experienced adversities were more likely to be diagnosed with ADHD as compared to Latinx and white children. And this is something that contributes to a lot of the inequities in our communities, because they oftentimes are seen as not having mental health conditions that are treatable in the usual way that we treat trauma. They're diagnosed with ADHD, which is the treatment tends to be much more about medication. And if they're diagnosed with a conduct disorder, there's more focus on the behavior and not the dysregulation that comes with the brain's response to toxic stress. I'll focus on that a little bit later in my presentation. Again, I know you've had a lot of information today about ACEs, but just wanted to underscore that we now have the data that shows that these adversities dramatically increase the risk of poor health outcomes and contribute to 9 of the 10 leading causes of death in the United States. And in addition to the ACEs, I mentioned these other factors that are toxic and that can really impact the stress response. As I mentioned, the community factors that were noted in Philadelphia and are part of the screening, racism, bullying, exposures to violence, and also food insecurity and housing insecurity. I just want to put up there a reminder of what the definition of toxic stress is that it's any prolonged activation of the stress response system that disrupts the development of brain architecture and other organ systems, and then ultimately increase the risk for stress-related diseases and cognitive impairment into the adult years. The evidence now shows that multiple systems are impacted by toxic stress. The obvious one, the neurologic and neuroendocrine system, also the immunologic systems, the inflammatory responses there, the endocrine system, and of course, we are now seeing that there are epigenetic and perhaps genetic changes that can happen. And I just want to point out some of the biologic stress markers that, and of course, they tend to be more concentrated in communities of color. So we see that there's more weathering, which is, when the allostatic load, which is the long-term result that happens when the body cannot create allostasis and respond and recalibrate the homeostasis that is necessary to respond to stress. We see that there's more weathering in African American communities. And there was the interesting study that was done at Tulane looking at telomeres, where higher maternal ACEs were associated with shorter infant telomere length across infancy. And they found that the children had more, were more were showing, more externalizing behaviors at 18 months. And to me, why that is important, oftentimes, if we follow the trajectory of this child who has had intergenerational transmission of the stress markers, and this probably has been going on for centuries, then this child who's showing externalizing behavioral problems will more than likely either get diagnosed with ADHD or conduct disorders, and that trauma screening is not being done. Just to focus back in on the neurologic impairment, because I think in pediatrics that perhaps is what you're going to be seeing more. What happens when the neurologic development is impaired. And so again, I sense that this was earlier discussed, so I'm not going to spend much time here, but we know that when there has been significant activation of the stress response system in a child, that there is the compromised executive functioning in the prefrontal cortex. There is challenges with arousal levels, hyperarousal due to what's happening in the amygdala, the challenges with attention and memory due to the impairment of the hippocampus. We also know that sleep and circadian rhythms are disrupted in the child. There will be compromised language development. And of course, in particular, what might be happening with oxytocin, impairment in social information processing. We know overall with children that there is much lower school engagement. I think the studies that were done with the group, Dr. Nadine Burke's group in Northern California, show that there was a lot more odds of kids with higher ACEs missing school due to health reasons, in particular asthma. These children showed much more difficulty completing tasks. And just in general with school, there was much more contact with households because there were problems in the schools. And then children with 3 or more ACEs had to repeat, 1 in 5 had to repeat a grade, and many were diagnosed with learning disabilities. And we know eventually adversities increase the vulnerability for the development of psychiatric conditions such as mood and personality and substance use disorders, in addition to the other biologic systems that I mentioned earlier were impaired. Just really quickly want to focus a little bit on PTSD because I think this is missed in many pediatric settings because the focus tends to be more behaviors, what is being reported, than a true screening for trauma. So just in terms of the diagnosis, it so resembles what if you only look behaviorally at symptoms where you're looking at the arousal and the reactivity, then these kids are much, and also when there is dissociation present, these kids are much more likely to be misdiagnosed, and the diagnosis of PTSD is not given. It's very happy that in New Orleans, working with the mental health system there, we were able to put in a policy that before any diagnoses of conduct disorders or ADHD were made with kids, that we had to assure that a proper trauma screening was done. And this is important because Louisiana writes up until recently, the most prescriptions for ADHD drugs, for stimulants. course, depression, that needs to be ruled out. Sometimes in a child, you can see some hyperactivity also. And this is the one that you're probably familiar with, because this is the one that a lot of non-mental health folks make, ADHD. There is the behavioral disorders, but I want to just land on what hopefully will be the resolution of some of this is the proposal for the next diagnostic manual, that we more appropriately consider the diagnosis of a developmental trauma disorder, which more adequately is going to reflect the impact on the developmental trajectory, what's happening in the brain and the brain dysregulation. So it would account for the emotional and somatic dysregulation, challenges with aggression and impulse control. It would address, this diagnosis would address the attentional problems, in particular the poor concentration. It would address some of the problems that these young people show with their relationships to themselves and to others. And it would also address issues of dissociation, where we see in kids with trauma, where they have these disconnected self states. So we're hoping that when this new diagnosis is introduced, the continued misdiagnosis of especially children of color, especially African-American males, the Surgeon General report showed that they were misdiagnosed and overdiagnosed with ADHD and with conduct disorders. This is an act of health inequity, because we're giving the wrong diagnosis and the wrong treatment. This is poor quality of care. And just briefly, I think that, it's important that, as was earlier mentioned, that there needs to be, what the pediatrician can do is develop a system of screening, not just for the child, and as happens in California, also if the caretaker is willing to have some screening for the caretaker. I think, as I have emphasized, because this is very important to me, I have seen this so many times, having to re-diagnose a child of color who was misdiagnosed, that really, if the proper trauma screenings are done, there can be some refrain from misdiagnosis of children. This really alters their trajectory. Some end up in prisons, in juvenile justice systems, and some end up on drugs. I know I'm seeing 20 to 30-year-old African-American males who were given this diagnosis were treated with stimulants, and they're now seeking these drugs. And I wonder, was this the proper diagnosis? Many of the times when I look back at their history, there was a lot of trauma that was not addressed. And of course, again, as was addressed in the earlier presentation, relying and referring on community resources. And a real opportunity, I think, as pediatricians you have, is to really support the mother-child dyad, to support the development of healthy attachment in that parent-child relationship, because we know that healthy nurturance and attachment is such a protective factor, and it helps to build resilience over the life course as traumas will inevitably happen. I saw that the previous presenters talked about Maine. I'll just kind of highlight ACE is aware. This is another public health population level approach to looking at trauma. And again, I think the more we deal with trauma in children, when we recognize there's historical trauma, there's the intergenerational transmission, there's current trauma, that we've gone a long way in addressing issues of inequities, mental health inequities in children of color. And so the ACEs Aware program, Screen, Treat, Heal in California, led by the Surgeon General, is really incentivizing, because Medi-Cal does reimburse for the extra time that is needed to do these screenings. And so I have a list here of the screening tools, the principles, as was earlier discussed. The providers, pediatricians, are trained in principles of trauma-informed care. The big ones that come from SAMHSA: to realize, respond, to not re-traumatize. These are very, very important, and there are multiple manuals and pathways for doing that. The importance of creating physical and emotional safety, addressing racial, ethnic, and gender inequities. That's part of the principles of being trauma-informed. So hopefully this conversation that I'm having gives you some understanding of how these inequities happen. And of course, trying to not be judgmental and focusing on whatever strengths and protective factors there are. And part of this California ACEs Aware is really the important role that the pediatrician has, or primary care practitioners in general, in educating patients on toxic stress and how they can regulate their stress response through building supportive relationships, promoting sleep in our children, healthy nutrition, physical activity, mindfulness and meditation. And sometimes I've heard people say kids won't do that. Well, I worked in a school, and whenever the kids, I did a group, and whenever they felt somewhat dysregulated, they would say, let's go get our yoga mat and let's go do some yoga. So kids will be mindful. In fact, sometimes they're very mindful, and they can be introduced to practices, to mindfulness practices and meditation. Of course, nature is very much a healer, and the good news is Louisiana is filled with a lot of gifts from nature. So, you know, I know in San Francisco, there is a group that's making prescriptions for kids to go on nature trails, thinking that that's so important. Of course, the referral to mental health care when the level of symptoms suggests a more intense level of care. And just, you know, there are tools, some of them were mentioned earlier, that are available, a lot of online tools that parents can be referred to help them in their healing journey for their children. And ultimately, you know, if we're going to overall achieve, I talk about the individual level of addressing inequities. If we look at the systems level, this came from some work that was done in Minneapolis in their public health department, and they worked with a Black Lives Matter group. And this is what they came up with, that part of creating health equity is just to accept that there has been racism in healthcare, and that these disparate health outcomes are really an extension of the historical context wherein Black lives have not mattered and have been devalued. We need to sit with that and to know that that is so. Then we have to understand how racism has shaped the disparities. There was always an attempt, and this goes all the way back to when people were enslaved, that poor health in people of color were perceived as due to biologic inferiority, not servitude and oppression. We have to be able to define and say what racism is. We need to then begin to center at the margins those who have been left out. So having, in a trauma-informed approach, we actually are patient-centered and allow their voice to be involved in their treatment planning. And ultimately, I think it's about just being able to value all lives as being worthwhile, that there's no hierarchy. And as such, when we recognize that inequities have led to these conditions, be willing to provide resources according to need and not privilege. We also know that an important part of addressing health inequities is to also have physicians of color, and so I'm very proud of these medical students who went to the enslaved quarters, and they were able to see themselves as their ancestors' wildest dream. We have to support, unlike what the AMA tried to do in the early 1900s, we have to support institutions that have equity and diversity and justice in the way they train physicians and give communities of color access to medical education. And my references, and I think my time is up.
Scan the QR code or go directly to the link to complete the evaluation and claim educational credit after viewing all of the sessions. Thank you for viewing the session. Please reach out if you have any questions or need additional information.